I'm Dr. Vinay Goyal. I'm an assistant professor of surgery with Texas Tech University. I'm also program director for bariatric surgery at UMC Medical Center. I'm a fellowship trained bariatric surgeon. I did my initial medical school in India, and then I did my surgical training here in US in New York, and after that I did fellowship for 1 year at Penn State University. I graduated in 2014 and practiced in Rhode Island from 2014 to 2018. And then I moved here in Lubbock, joined Texas Tech University as assistant professor, and I specialize in bariatric surgery and minimally invasive surgery. I would encourage you to watch this webinar and gain more knowledge about what bariatric surgery is all about. I look forward to seeing you and helping you in your journey towards a healthier weight.
Today we're going to go over the program that we have here at University Medical Center. We're going to talk about the impact of obesity, who qualifies for bariatric surgery. We talk about the program requirements, talk about patient experience, as well as what is required to have the bariatric surgery. Here at University Medical Center and Texas Tech University Health Science Center, we're a bariatric center of excellence. Essentially what that means is accredited by American College of Surgeons and American Society of Bariatric Metabolic Surgery, which is accredited for programs that are high quality in surgery for bariatric surgery, as well as low complication and high volume center. Obesity is an epidemic disease. This is considered a disease by American Medical Association. Approximately 2/3 of Americans are overweight, and about 1/3 of Americans are in an obese category. By 2026, it's predicted that over 40% of patients or population will be obese. The estimated annual medical cost for obesity is about $190 billion, and this is about 21% of annual medical costs spent in the United States. The medical cost for people that are obese is approximately about $1,400 higher than patients that are non-obese. Obesity is defined by NIH criteria. Overweight patients are considered with BMI of 25 to 29.9. Essentially what BMI is, what we take your weight and your height and we put in a formula, and this is how we get your BMI. Obesity for class 1 is considered 30 to 34.9, and BMI of 35 to 39.9 puts you at a class 2 obesity, and this is where the indication for bariatric surgery starts. Extremely obese or class 3 is considered BMI of 40 and higher. Obesity can cause many comorbidities. One of those considered type 2 diabetes that can affect every organ in your body, such as your heart, such as your vessels, eyes. Heart disease, again, it's as a result of obesity. High blood pressure can also be related to obesity. High cholesterol. Sleep apnea, which is a condition where people stop breathing at night and they can snore and feel tired throughout the day. If you haven't been diagnosed with that, this is something that we usually do workup prior to the operation. Acid reflux. There are some of the cancers also that have been associated with obesity, such as colon cancer, breast cancer, pancreatic cancer, and prostate cancer. Depression, fatty liver disease. Nowadays, one of the most common reasons for liver failure is actually fatty liver disease that leads into cirrhosis. These are all reversible with bariatric surgery. Osteoarthritis and joint pain. For obvious reasons, patients carry a lot of weight on their joints, and that can lead to osteoarthritis. Stress urinary incontinence, not being able to control your urine, and again, with weight loss, that can get better. Also, female reproductive health disorders, such as infertility, sexual dysfunction can be related to obesity as well, which again, with weight loss, all of those can get better. Obesity is related to genetic and environmental factors. Nowadays, many of us, our jobs are replaced with computers, sitting at the desk all day. There is increased media use, such as using video games and televisions. Automobile-oriented communities and reliance on motorized transportation. Limited opportunities for activity throughout the day during the workday, and limited time for daily physical education recess in schools. All these can lead to obesity, and they all start from childhood. Many patients try diet and exercise. Obviously, prevention is critical and needs to start in childhood. Diet and exercise in about 95% of patients fails by itself. This is a yo-yo effect. Patient lose a little bit of weight and gain it back, or sometimes even more. And sometimes they can't even exercise because due to the comorbidities such as osteoarthritis or having heart condition, or sometimes patients feel embarrassed to go even to the gym and exercise. So what are the treatments of obesity? Obviously, there's medical weight loss available that patients that do not qualify for bariatric surgery that can try medical weight loss, or patients who do not have insurance or they may not desire surgery for bariatric surgery can try medical weight loss. Surgery is one of the only viable long-term solutions for weight loss that the weight can be sustained. There are multiple surgical options available that we will go through throughout this webinar. Long-term survival by about 10 to 15 years for patients who have significant weight loss. This is one of the benefits of bariatric surgery. And obviously, it can improve the quality of life long-term. The options, diet and exercise. Most patients with diet and exercise, they can lose about 10% of their excess body weight, but many times it's a yo-yo effect. There's also drugs that many of these drugs have minimal sustained weight loss long-term. Again, can give you about 10 to 15% excess body weight loss, but some of these drugs also have side effects. Weight loss surgery, we have long-term data that shows about 55 to 75% excess body weight loss, and the weight can be sustained long-term. Is surgery the key? Obviously, it's a very successful tool to help you lose a lot of weight. However, if you don't change your eating habits and lifestyle, this may not work. Patients need long-term follow-up with us here at University Medical Center to make sure your labs are good long-term and you don't develop any vitamin deficiencies. And calorie restriction is there for the rest of your life. So this is something for patients to understand prior to going to surgery. Who qualifies for bariatric surgery? Patients must have BMI over 35 with comorbidities of obesity, which can be diabetes, high blood pressure, high cholesterol, sleep apnea, and many other comorbidities that we previously talked about, or a BMI of 40 by itself. The other workup that needs to be done, we do a thorough workup to make sure there's no endocrine disorders that is contributing to your obesity. You have to be an acceptable operative risk prior to the operation. You have a good understanding of what are the risks of the operation, absence of drug or alcohol problems, no uncontrolled psychological conditions, and after obtaining consensus from our bariatric team evaluation, and we can go ahead and schedule your surgery. It is absolutely a must for all patients to be nicotine-free prior to the surgery. And patients have to have dedication to go through this surgery and be dedicated to the new lifestyle changes for the rest of their life. About 99% of procedures that we perform at University Medical Center, they are done laparoscopically. Many years ago, bariatric surgeries were performed open, which means patients get about 10 to 15 centimeter long midline incision, which means more pain, longer time for recovery. However, with laparoscopy, we're able to do the surgery in a very small incision using our laparoscopic equipment and instruments and perform the surgery. Outcome is the same as doing open surgery. Obviously, it's a faster recovery and less wound infections. So now we're going to go over the options for bariatric surgery. One of the options available is lap band. However, we do not offer this here in our center due to the complications that are associated with lap band, such as lap band slippage, infection of the port, and band erosion, and also requires long-term maintenance of the band, and the weight loss is not as good. And these are the reasons that we do not offer this operation to our patients here at University Medical Center. However, if you do have a lap band, we do still see you, and if you don't have any problems or complications, we can make adjustment to your lap band in our clinics. One of the most commonly performed procedures nowadays is laparoscopic sleeve gastrectomy. This is purely a restricted procedure, which means we remove 80% of your stomach. It goes from a football-sized shaped stomach to banana size. And what it does, it reduces size, so when you eat small amount of healthy food, you get satisfied and you don't want to eat as much. Plus, some of the hunger hormones named ghrelin will decrease significantly, so most patients don't feel hungry as much. This is one of the reasons that they're able to lose significant amount of weight and be able to maintain it. There's long-term data available for laparoscopic sleeve gastrectomy, which shows 50 to 70% excess body weight loss in about 1 to 2 years. Risk of the laparoscopic sleeve gastrectomy and benefits, again, there's fewer complications associated with this procedure. It's a faster operation. The biggest complication associated with this operation is leak, which is about less than 1% along the staple line where we remove the stomach. We do a leak test intraoperatively to ensure that there is no leak there, and we check in a contrast study the next day to make sure there is no leak. There's less vitamin deficiency associated with this operation. It's a shorter operative time. There is no anastomosis or rerouting the intestines. And it can also be revised to gastric bypass or duodenal switch later on in life if weight loss is not adequate. Next option is gastric bypass. Again, a very good operation. Again, this is done laparoscopically with small incisions. It's a combination of restrictive and malabsorptive procedure, which patients get restriction from a small pouch that we create, and we also bypass in part of a small bowel and intestine that doesn't absorb as much fatty foods. This was first done in 1967 and has been done laparoscopically for many years, and we have long-term data available that shows 50 to 75% excess body weight loss over 20 years follow-up. So what are the advantages of gastric bypass? We have long-term data available that shows it's very successful. There is rapid initial weight loss with this procedure. There is rapid reduction in weight-related illnesses such as diabetes, hypertension, which we can also see with gastric sleeve. There is fast healing time, early satiety, and dumping syndrome is a condition that patients need to be aware of. This is a condition where with high sugar load that goes through the pouch into the small bowel, patients can have dizziness, increased heart rate, and diarrhea. And this is one of the conditions that can be a disadvantage. Where for some patients that have weakness to sweets, this may be an advantage that would prevent them from having high calorie and high sweets type of foods. Disadvantages are that this alters your anatomy. It is a longer operative time compared to sleeve, and patients require lifetime vitamins and mineral supplementations and a little bit of higher vitamin deficiency as compared to sleeve. However, regardless of which operations you receive, you will still need vitamins for the rest of your life. And again, caution must be taken when patients are on anti-inflammatory drugs such as ibuprofen, Advil, and Motrin long-term, because it can cause ulceration at the connection sites. And this is something that we go over prior to scheduling you for surgery. Here is another type of weight loss surgery, biliopancreatic diversion with duodenal switch. This is an operation that usually we perform this in a two-stage where we perform the gastric sleeve, and this is something that's offered to patients with very high BMIs, where gastric sleeve is done first, and later we can convert it to duodenal switch. And again, this is a combination of restrictive and malabsorptive operation. Patients have the highest amount of weight loss, which is about 80% excess body weight loss, but it also has the highest amount of risks. So due to the fact that this is a very malabsorptive procedure, patients can have very liquidy bowel movements. They can have abdominal bloating, malodorous stool, or gas. Due to the fact that this is a very malabsorptive operation, patients will require lifetime vitamins and supplementations. And also due to alteration of anatomy, patients are at higher risk for developing gallstones. So we will evaluate gallbladder, and we do remove your gallbladder at the same time with this operation. In general, what are the risks of surgeries? And these complications and risk factors can be associated with any operations that we went over previously. There can be intestinal leakage at the connection sites or staple line. Again, all these that we talk about is less than 1%. And nowadays, doing this laparoscopic bariatric surgeries are safe as removing your gallbladder. Acute gastric remnant dilation or signs of bowel obstruction. Bowel obstruction can happen long-term. Cardiopulmonary myocardial infarction or blood clots in the legs or blood clots going to the lungs. That can happen with any surgery that you would have because of the higher risks that are associated with obese patients undergoing general surgery. In general, we give everybody blood thinner to reduce these risks. around the time of surgery. And the biggest thing that can help is actually getting the patients out of bed and walking around to reduce those risks. Late complications that can happen with any of these surgeries: stricture or narrowing of the lumen with gastric sleeve or gastric bypass, or duodenal switch, anemia due to vitamin deficiencies or iron malabsorption, calcium deficiencies. And this is the reason that we have patients on multivitamins for the rest of their life. And as long as you're taking your multivitamins, you would not be at risk for vitamin deficiency. So to summarize, the most two common operations performed are laparoscopic gastric sleeve and laparoscopic gastric bypass. Here is a comparison between the two operations. They're both done laparoscopically. Length of surgery is a little bit longer with gastric bypass. Time in the hospital, it's very similar. It could be anywhere from 1 to 3 days with gastric bypass, sometimes maybe a day longer in the hospital. Return to work could be anywhere from 2 to 4 weeks, depending on the patient. Weight loss, very similar between the two operations with gastric sleeve. Weight loss of 50 to 70% of your excess body weight at about 1 to 2 years versus 50 to 75% with gastric bypass at 1 to 2 years. And again, gastric sleeve, it's a permanent operation where 2/3 of your stomach is removed, and gastric bypass, your anatomy is changed, but in an event where it's absolutely necessary to reverse, it's reversible. And dumping syndrome is another thing that you need to be aware of with gastric bypass. What are signs and symptoms of complications after surgery that you need to be aware of? Elevated heart rate sustained in 1-teens, fever of 100.5 or greater, shortness of breath can be a sign of infection or blood clots in the lungs, or myocardial infarction or heart attack. Excessive abdominal pain can be a concerning sign that we need to know immediately. Vomiting, dehydration can be also a risk. And low blood pressure. These are all the things that we need to be aware of if it does happen when you go home. Here's the list of vitamins and medications that's required for you to take. Every patient should be on chewable multivitamins for the rest of your life, or regular multivitamins. For patients with menstrual cycles, they should include iron supplements or vitamins with iron, calcium citrate, and vitamin D and vitamin B12 are required. So this slide summarizes the benefits of weight loss surgery. Starting from head to toe, depression and migraine headaches, pseudotumor cerebri, all these can significantly improve. Obstructive sleep apnea, again, a condition where people stop breathing at night because of the weight in their neck, and the fat that deposits in the neck causes obstruction of the airway. At about 6 months, most patients are off of their CPAP machine. Asthma, high cholesterol, high blood pressure, cardiovascular risk significantly reduces. Acid reflux with weight loss improves significantly. Diabetes, this is one of the only options for cure in diabetes for type 2 patients. And again, majority of patients at 5 years, they have normal hemoglobin A1C, which indicates how well controlled your diabetes has been long term. Polycystic ovarian syndrome. Many patients are not able to get pregnant. With weight loss, chance of fertility increase significantly. Joint pain will improve significantly. And mortality at 5 years can decrease by about 89%. Again, this is very significant. And quality of life for 95% of patients are improved significantly. So what should you expect prior to the surgery? You will see one of us in clinic. We obtain a complete history and physical. We obtain routine labs. And depending on your comorbidities, we may require medical clearances or cardiology clearance. Most patients will undergo endoscopy or evaluate your stomach prior to the surgery to make sure we don't find anything abnormal prior to operating on your stomach. And also, you will see our registered dietitian throughout your journey to help you with your diet preoperatively and after surgery. And in addition, you will see our psychologist who's going to evaluate you to make sure you have a good understanding of what weight loss surgery means and to make sure there's no behavioral issues that will prevent you from being successful after surgery. We do need a referral from your primary care doctor, and once all those are obtained, then we'll sit down and obtain informed consent, go over the procedures, and depending on what your preference is and what we will recommend, we'll pick an operation schedule for surgery. And obviously, it's very important that we have optimize your blood sugars prior to the operation, and it's absolutely necessary that every patient is smoke-free prior to the operation. So preoperatively, we put patients on special diet, which consists of clear liquids and protein shakes, and it is very important that you comply with this diet. And the purpose of this is to help you lose some more weight and also reduce the size of your liver, which sits over the stomach, so to make the surgery safer and easier. After surgery, your diet consists of the similar diet as you were on 2 weeks before, and gradually after 2 weeks, we increase your diet to pureed and soft proteins. And after about 5 to 6 weeks, you will go to regular healthy proteins. In general, we recommend no heavy lifting greater than 20 pounds for about 2 weeks, as long as the procedure is done laparoscopically. And for follow-ups, you will see us 2 weeks after the operation. If in any case you do have a drain, you will see us 1 week after the operation to remove the drain. You will have regular visits and follow up with us in the first year and also yearly after. For the first year, we will see you 6 weeks after your operation, 3 months after your operation, 6 months, and 1 year, and then yearly after. So finally, surgery is a tool that's going to help you lose a significant amount of weight. It's a very successful tool. However, it's just a tool that's going to help you lose weight. And you need to be committed for the rest of your life to a healthier lifestyle. You got to think about your options seriously, and we're always here to help you. Again, thank you for paying attention to this webinar and choosing us for your bariatric surgery and bariatric care here at Texas Tech University and University Medical Center.